Welcome back to NCLEX Made Easy 91. If you're preparing for the NCLEX and want to master renal system questions with confidence, you're in the right place. In today's video, I'll walk you through high-yield NCLEX-style questions with clear rationales and smart strategies that can help you tackle even the trickiest renal topics.
This isn't just practice. It's focused preparation that boosts your test-taking skills and deepens your understanding. And here's the best part. The most valuable strategies and test tips are spread throughout the video, so stay locked in till the end. Those last questions are high yield and frequently appear on the actual NCLEX exams.
Let's dive in and get you one step closer to becoming an RN.
1. A client with acute kidney injury has a serum potassium level of 6.2 milliequivalents per liter. Which intervention should the nurse anticipate first? A. Administer sodium polystyrene sulfonate. B. Prepare the client for hemodialysis. C. Administer intravenous calcium gluconate. D. Encourage a low potassium diet. Answer C. Administer intravenous calcium gluconate. Rationale: a potassium level of 6.2 milliequivalents per liter indicates hyperkalemia, a life-threatening electrolyte imbalance. Hyperkalemia affects cardiac conduction and increases the risk of lethal arrhythmias, like ventricular fibrillation. Calcium gluconate does not lower potassium levels, but it stabilizes the cardiac muscle membranes, protecting the heart from the dangerous effects of high potassium. It is the most immediate action to prevent cardiac complications, while longer-term potassium-reducing measures are implemented. Strategy: in NCLEX, always prioritize safety and preservation of life. Use the ABCs, airway, breathing, circulation, and identify interventions that act fastest to prevent deterioration. When multiple answers are correct, choose the one that buys time for definitive treatment. Here, calcium stabilizes, while dialysis or medications reduce potassium. 2. Which of the following urine characteristics is most consistent with nephrotic syndrome? A. Hematuria. B. Polyuria. C. Proteinuria. D. Glucoseuria. Answer C. Proteinuria. Rationale: nephrotic syndrome is a kidney disorder characterized by massive protein loss due to increased permeability of the glomerular membrane. Proteinuria exceeding 3.5 grams per day is a hallmark of the condition. This protein loss leads to hypoalbuminemia, edema, and hyperlipidemia. Hematuria is more typical of nephritic syndrome, and glucoseuria typically results from uncontrolled diabetes. Polyuria is associated with diabetes insipidus or diabetes mellitus, not nephrotic syndrome. Strategy: master the clinical distinctions between nephrotic versus nephritic syndrome. Keywords like massive protein loss, frothy urine, and edema should immediately make you think of nephrotic syndrome. 3. The nurse is teaching a client with chronic kidney disease about dietary restrictions. Which food should the client avoid? A. Apples. B. Spinach. C. White rice. D. Chicken breast. Answer: B. Spinach. Rationale: clients with chronic kidney disease, CKD, must limit their intake of potassium, phosphorus, and sodium. Spinach is very high in potassium and oxalates, which can accumulate due to the kidney's impaired ability to excrete them. This could lead to cardiac arrhythmias or worsening renal function. Apples and white rice are low in potassium and safe, while chicken breast is a good lean protein when portioned properly. Strategy: when faced with nutrition questions, focus on what the kidney cannot eliminate. Memorize common high potassium foods: bananas, oranges, spinach, potatoes, tomatoes, and dairy. Avoid these in CKD unless advised otherwise by a renal dietitian. 4. A client with peritoneal dialysis complains of abdominal pain and cloudy effluent. What is the nurse's priority action? A. Administer pain medication. B. Notify the healthcare provider. C. Encourage deep breathing exercises. D. Document findings and reassess in 30 minutes. Answer: B. Notify the healthcare provider. Rationale: Cloudy dialysate fluid and abdominal pain are classic signs of peritonitis, a serious and potentially fatal infection associated with peritoneal dialysis. Prompt notification of the provider is critical because it allows for immediate culture, diagnosis, and administration of intraperitoneal antibiotics. Pain medication alone would mask the symptoms, and reassessing later delays life-saving treatment. Strategy: recognize red flags in client presentations. In peritoneal dialysis, cloudy outflow is never normal and always suggests infection. Prioritize actions that initiate diagnostic or therapeutic intervention. 5. Which laboratory result is most concerning in a client with chronic kidney disease? A. Hemoglobin, 10 grams per deciliter. B. Calcium, 7.5 milligrams per deciliter. C. Potassium, 4.8 milliequivalents per liter. D. BUN, 28 milligrams per deciliter. Answer: B. Calcium, 7.5 milligrams per deciliter. Rationale: hypokalcemia is a common complication of CKD due to decreased production of activated vitamin D by the kidneys, which is necessary for calcium absorption. Low calcium can cause muscle cramps, tetany, and seizures. Hemoglobin of 10 grams per deciliter is slightly low but expected in CKD due to decreased erythropoietin. A potassium of 4.8 milliequivalents per liter is normal, and a BUN of 28 milligrams per deciliter is elevated but not immediately life-threatening. Strategy: in labs, focus on critical values that threaten life, severe electrolyte imbalances, abnormal cardiac markers, or signs of organ failure. Hypocalcemia in CKD must be taken seriously due to its neuromuscular effects. 6. A client with end-stage renal disease reports pruritus. What nursing intervention is most appropriate? A. Encourage frequent bathing with hot water. B. Apply antihistamine cream and monitor for relief. C. Provide potassium-rich foods to prevent dry skin. D. Restrict fluid intake to reduce itching. Answer: B. Apply antihistamine cream and monitor for relief. Rationale: pruritus in end-stage renal disease, ESRD, is primarily caused by uremia and the buildup of nitrogenous waste products which irritate the skin. Topical antihistamines can relieve itching, while keeping skin moisturized is also important. Hot water can worsen dryness and itching. Potassium-rich foods are contraindicated in ESRD. Fluid restriction does not directly help with itching unless fluid overload is present. Strategy: when a symptom like pruritus is presented, think of etiology and safe symptomatic relief. Avoid actions that may worsen the condition, like hot water. Choose interventions that provide comfort and are non-invasive first.
7. Which finding best indicates effective treatment of acute glomerulonephritis? A. Decreased urine output. B. Periorbital edema. C. Normal blood pressure. D. Presence of hematuria. Answer: C. Normal blood pressure. Rationale: acute glomerulonephritis is often marked by hypertension, hematuria, edema, and reduced renal function. One of the key indicators that treatment is working is the return of blood pressure to normal, showing improved renal function and fluid balance. Hematuria and edema may persist longer, even with improvement. Decreased urine output indicates worsening function. Strategy: when evaluating effectiveness of treatment, look for normalization of vital signs and lab values, not just absence of symptoms. Blood pressure is a strong measure of renal and fluid status. 8. What is the priority teaching point for a client with a new arteriovenous AV fistula? A. Avoid lifting heavy objects with the arm. B. Sleep on the arm with the fistula. C. Use the arm for blood pressure checks. D. Keep the arm elevated at all times. Answer: A. Avoid lifting heavy objects with the arm. Rationale: an AV fistula is a lifeline for hemodialysis. Protecting it is critical to avoid clotting or trauma. The client must avoid heavy lifting, tight clothing, or any pressure on that arm. BP checks, IVs, and blood draws are never performed on the fistula arm. Sleeping on the arm or elevating it unnecessarily can impair blood flow. Strategy: With any vascular access device, prioritize protection and patency. Know the specific do's and don'ts to prevent complications like thrombosis or access loss. 7. Which finding best indicates effective treatment of acute glomerulonephritis? A. Decreased urine output. B. Periorbital edema. C. Normal blood pressure. D. Presence of hematuria. Answer: C. Normal blood pressure. Rationale: acute glomerulonephritis is often marked by hypertension, hematuria, edema, and reduced renal function. One of the key indicators that treatment is working is the return of blood pressure to normal, showing improved renal function and fluid balance. Hematuria and edema may persist longer, even with improvement. Decreased urine output indicates worsening function. Strategy: when evaluating effectiveness of treatment, look for normalization of vital signs and lab values, not just absence of symptoms. Blood pressure is a strong measure of renal and fluid status. 8. What is the priority teaching point for a client with a new arteriovenous AV fistula? A. Avoid lifting heavy objects with the arm. B. Sleep on the arm with the fistula. C. Use the arm for blood pressure checks. D. Keep the arm elevated at all times. Answer: A. Avoid lifting heavy objects with the arm. Rationale: an AV fistula is a lifeline for hemodialysis. Protecting it is critical to avoid clotting or trauma. The client must avoid heavy lifting, tight clothing, or any pressure on that arm. BP checks, IVs, and blood draws are never performed on the fistula arm. Sleeping on the arm or elevating it unnecessarily can impair blood flow. Strategy: with any vascular access device, prioritize protection and patency. Know the specific do's and don'ts to prevent complications like thrombosis or access loss. 9. A client with renal failure has a GFR of 15 millis minute. What stage of chronic kidney disease is this? A. Stage 1, B. Stage 2, C. Stage 3, D. Stage 5. Answer: D. Stage 5. Rationale: the glomerular filtration rate, GFR, is the best measure of kidney function. A GFR less than 15 millis per minute, bringing 1.73 square meters, indicates stage 5 CKD, or end-stage renal disease, ESRD. At this point, the client will likely need dialysis or kidney transplantation. Stage 1 is a GFR great equal to 90, Stage 2 is 60 to 89, Stage 3 is 30 to 59, and Stage 4 is 15 to 29. Strategy: memorize the GFR stages as they are essential for diagnosing kidney disease progression and guiding treatment. It's commonly tested on NCLEX. 10. Which medication should be held before dialysis? A. Erythropoietin. B. Lisinopril. C. Calcium acetate. D. Furosemide. Answer: B. Lisinopril. Rationale: lisinopril is an ACE inhibitor that lowers blood pressure. Hemodialysis can also reduce blood pressure. Taking both can result in severe hypotension during dialysis, which can lead to dizziness, falls, or even stroke. It is usually withheld on dialysis days. Erythropoietin and phosphate binders like calcium acetate are often administered after dialysis. Furosemide might be used in non-anuric patients. Strategy: when a question mentions dialysis, think about how the procedure affects hemodynamics. Avoid meds that could interact negatively with fluid shifts or be removed during dialysis.
11. A client with renal calculi is advised to strain their urine. What is the rationale for this instruction? A. To check for signs of hematuria. B. To collect stones for analysis. C. To measure output accurately. D. To reduce infection risk. Answer: B. To collect stones for analysis. Rationale: straining urine allows for collection of past kidney stones, which can then be analyzed in a lab. Knowing the stone's composition, e.g., calcium oxalate, uric acid, struvite, cysteine, is essential for identifying the underlying cause and implementing appropriate dietary and pharmacologic treatment to prevent recurrence. Hematuria is common with stones, but does not require straining. Measuring output and infection control are important, but not the reason for this instruction. Strategy: when the question is about why a client should do something, look for diagnostic or treatment implications. In this case, identifying the stone type is key to individualized prevention strategies. 12. The nurse is reviewing the lab report of a client with acute pyelonephritis. Which finding is expected? A. Low white blood cell count. B. Negative urine culture. C. Presence of white cell casts. D. Proteinuria without bacteria. Answer: C. Presence of white cell casts. Rationale: white blood cell, WBC cast in the urine are indicative of kidney inflammation, especially in pyelonephritis, which is an upper urinary tract infection involving the renal pelvis. WBC casts are formed in the renal tubules, signifying that the infection has reached the kidney itself rather than remaining in the bladder. Low WBC count and negative cultures are inconsistent with infection. Proteinuria without bacteria is more suggestive of glomerular disease. Strategy: no urinary sediment findings. Casts are very specific clues. WBC casts, pyelonephritis. RBC casts, glomerulonephritis. Fatty casts, nephrotic syndrome. These details are heavily tested on NCLEX. 13. Which symptom is most concerning in a client with urinary retention? A. Small frequent voiding. B. Suprapubic fullness. C. Fever and chills. D. Inability to void. Answer: D. Inability to void. Rationale: complete inability to void is the most concerning symptom because it can cause bladder distension, urinary tract infection, acute kidney injury, or even bladder rupture. This is a urological emergency. Small frequent voiding, called overflow incontinence, and suprapubic fullness are common in partial retention, while fever and chills may indicate infection but are not as urgent as total urinary blockage. Strategy: when a question asks for the most concerning finding, look for signs that suggest emergency or irreversible damage. In this case, the inability to void is a critical obstruction. 13. Which symptom is most concerning in a client with urinary retention? A. Small frequent voiding. B. Suprapubic fullness. C. Fever and chills. D. Inability to void. Answer: D. Inability to void. Rationale: complete inability to void is the most concerning symptom because it can cause bladder distension, urinary tract infection, acute kidney injury, or even bladder rupture. This is a urological emergency. Small frequent voiding, called overflow incontinence, and suprapubic fullness are common in partial retention, while fever and chills may indicate infection but are not as urgent as total urinary blockage. Strategy: when a question asks for the most concerning finding, look for signs that suggest emergency or irreversible damage. In this case, the inability to void is a critical obstruction. 14. Which client behavior indicates understanding of fluid restriction for renal failure? A. I will drink water only when I'm thirsty. B. I will measure all foods that become liquid at room temperature. C. I will increase my juice intake to maintain hydration. D. I will only restrict sodium, not fluids. Answer: B. I will measure all foods that become liquid at room temperature. Rationale: fluid restriction in renal failure must include all intake sources, including soups, ice cream, gelatin, and even ice chips. Anything that becomes liquid at room temperature. This is vital for preventing fluid overload, hypertension, and pulmonary edema. Saying "only when I'm thirsty" is vague and may not effectively limit intake. Increasing juice is unsafe. Sodium and fluid restriction are usually combined. Strategy: education-based NCLEX questions require you to identify the option showing the most comprehensive understanding. Look for specific and measurable behaviors. 15. What is the primary goal of erythropoietin therapy in chronic kidney disease? A. Increase urine output. B. Correct anemia. C. Reduce potassium. D. Control blood pressure. Answer: B. Correct anemia. Rationale: in CKD, the kidneys fail to produce adequate erythropoietin, the hormone that stimulates red blood cell production in the bone marrow. This results in anemia, often seen as fatigue, pallor, and low hemoglobin or hematocrit levels. Administering synthetic erythropoietin, e.g., epoetin alpha, stimulates erythropoiesis and improves oxygen delivery to tissues. It does not affect urine output, potassium, or BP directly. Strategy: link each medication with its core function. Even if it has secondary effects, NCLEX often asks for the primary therapeutic goal. Don't be distracted by unrelated symptoms. 16. A client reports foamy urine. What is the most likely cause? A. Glycosuria. B. Hematuria. C. Proteinuria. D. Bacteriuria. Answer: C. Proteinuria. Rationale: foamy or frothy urine is a classic sign of proteinuria, indicating that large proteins like albumin are leaking into the urine due to glomerular damage. Protein reduces urine surface tension, creating bubbles. Glycosuria, glucose in urine, occurs in uncontrolled diabetes and does not usually cause foam. Hematuria causes reddish or brown urine, and bacteriuria may cause cloudiness, odor, or burning, not foam. Strategy: visual urine changes are commonly tested. Know what color, clarity, and consistency changes indicate. Match each abnormality to the most likely cause. 17. A client receiving furosemide is at risk for which complication? A. Hypernatremia. B. Hyperkalemia. C. Hypokalemia. D. Hypermagnesemia. Answer: C. Hypokalemia. Rationale: furosemide is a loop diuretic that acts on the loop of Henle to increase sodium, potassium, and water excretion. A major side effect is hypokalemia, which can cause muscle weakness, cramps, and life-threatening arrhythmias. It also depletes magnesium and calcium. Hyperkalemia and hypermagnesemia are not associated with loop diuretics. Hypernatremia is rare because water and sodium are excreted together. Strategy: always recall electrolyte side effects of diuretics. Loop diuretics, furosemide, equals lose nashbus, cashbus, C-stu-mus, migadream-stu-mus. Thiazides equals lose nashbus, cashbus, retain C-stu-mus. Potassium sparing equals retain cashbus. These associations are testable NCLEX facts. 18. What dietary recommendation is appropriate for a client with calcium oxalate kidney stones? A. Increase spinach and nuts. B. Increase dairy intake. C. Avoid foods high in oxalate. D. Restrict fluids to reduce urine output. Answer: C. Avoid foods high in oxalate. Rationale: calcium oxalate is the most common type of kidney stone. Foods high in oxalate, such as spinach, nuts, tea, chocolate, and beets, should be limited. Fluid intake should be increased, not restricted, to flush out the urinary tract and prevent crystal formation. Dairy intake may be moderately allowed, but in balance. Increasing oxalate worsens the risk. Strategy: for renal stones, dietary management is specific to stone type. If calcium oxalate is identified, know to avoid oxalate-rich foods and encourage hydration. 19. A client is undergoing continuous bladder irrigation. The urine is bright red. What should the nurse do first? A. Increase the irrigation flow rate. B. Clamp the catheter. C. Notify the provider immediately. D. Document the finding as expected. Answer: A. Increase the irrigation flow rate. Rationale: continuous bladder irrigation, CBI, is often used post-TURP, transurethral resection of the prostate, to prevent clot formation. Bright red urine indicates active bleeding or inadequate irrigation, which can cause clots and bladder distension. Increasing the flow rate helps flush clots and bleeding sites, preventing obstruction. Clamping the catheter worsens retention. Notify the provider if bleeding persists despite intervention. Strategy. Always act on what you can do as a nurse before escalating. In post-op CBI, your first action is often to adjust flow, not to call immediately, unless the situation is uncontrolled or unstable. 20. What is the best indicator of fluid balance in a client with acute kidney injury? A. Urine output. B. Blood pressure. C. Serum sodium level. D. Daily weight. Answer. D. Daily weight. Rationale. Daily weight is the most accurate and sensitive indicator of fluid status, especially in clients with compromised renal function. A change of 1 kilogram, 2.2 pounds, in 24 hours reflects a fluid gain or loss of 1 liter. Urine output may not be reliable in oliguric or anuric AKI. Blood pressure and sodium levels can be influenced by many other factors. Daily weights are simple, cost-effective, and clinically significant. Strategy. For fluid monitoring, choose the objective, quantifiable measure that reflects total body fluid volume. NCLEX consistently tests this point. Daily weight grow back to the intake/output or labs for fluid status. 21. A client with chronic kidney disease is prescribed sevelamer with meals. What is the primary reason for this medication? A. To lower potassium levels. B. To bind dietary phosphorus. C. To reduce fluid retention. D. To increase calcium absorption. Answer. B. To bind dietary phosphorus. Rationale. Sevelamer is a phosphate binder given to clients with CKD to manage hyperphosphatemia, a common complication due to the kidney's inability to excrete excess phosphorus. When taken with meals, it binds to dietary phosphate in the gastrointestinal tract, preventing its absorption. Lowering phosphorus helps prevent secondary hyperparathyroidism and bone demineralization. This drug does not affect potassium or fluid volume, and it does not directly increase calcium. Strategy. Know that CKD disturbs mineral metabolism, especially calcium and phosphate balance. On NCLEX, when phosphate binders are mentioned, focus on timing with meals and preventing complications like renal osteodystrophy. 22. A client with nephrotic syndrome is experiencing severe edema. What is the primary mechanism behind this symptom? A. Decreased sodium excretion. B. Increased glomerular filtration rate. C. Loss of plasma proteins. D. Elevated serum creatinine levels. Answer. C. Loss of plasma proteins. Rationale. In nephrotic syndrome, the glomerular capillary walls become abnormally permeable, allowing large proteins, especially albumin, to leak into the urine. This leads to hypoalbuminemia, reducing the plasma oncotic pressure that normally keeps fluid inside blood vessels. As a result, fluid shifts into the interstitial space, causing generalized edema, anasarca. Sodium retention and creatinine levels may be involved, but the primary cause of the edema is protein loss. Strategy. Always relate symptoms to pathophysiology. In edema-related questions, ask yourself, is it oncotic or hydrostatic pressure causing the shift? In nephrotic syndrome, think albumin loss equals low oncotic pressure equals edema. 23. A nurse is caring for a client who had a renal biopsy. Which post-procedure instruction is most important? A. Ambulate early to prevent pneumonia. B. Apply heat to the site to reduce pain. C. Avoid heavy lifting for several days. D. Drink fluids to flush the kidneys. Answer. C. Avoid heavy lifting for several days. Rationale. A renal biopsy involves inserting a needle into the kidney to obtain a tissue sample. This procedure can cause bleeding, so the priority post-procedure instruction is to avoid activities that increase intra-abdominal pressure, such as lifting, straining, or vigorous movement. Hemorrhage is the most serious risk. Heat should not be applied to the biopsy site, and while hydration is good, preventing bleeding is the priority. Strategy. After any invasive organ procedure, especially vascular organs like the kidney or liver, always prioritize preventing bleeding. Look for answers involving activity restriction, vital sign monitoring, or pressure application. 24. A client with glomerulonephritis presents with cola-colored urine. What is the most likely cause? A. High bilirubin levels. B. Red blood cell breakdown in the urine. C. Increased urobilinogen excretion. D. Bacterial overgrowth in the bladder. Answer: B. Red blood cell breakdown in the urine. Rationale: cola-colored, tea-colored urine in glomerulonephritis results from microscopic hematuria, where red blood cells leak into the nephrons and are broken down, giving the urine a dark appearance. This is different from bright red hematuria seen in lower tract bleeding. Elevated bilirubin or urobilinogen causes dark yellow or brown urine, not cola-colored. Bacterial growth typically leads to cloudy or foul-smelling urine, not discoloration from blood. Strategy: recognize that urine color and consistency are diagnostic clues. Match descriptions like cola-colored with glomerular bleeding, not hepatic or bladder issues. 25. A nurse is reviewing medications for a client with end-stage renal disease. Which medication is most likely to be held before dialysis? A. Multivitamin. B. Amlodipine. C. Atenolol. D. Lisinopril. Answer: D. Lisinopril. Rationale: lisinopril, an ACE inhibitor, is commonly held before dialysis because both the medication and dialysis independently lower blood pressure. Taking it prior to dialysis increases the risk of hypotension during treatment, which may lead to dizziness, decreased perfusion, or syncope. Amlodipine may be continued depending on individual tolerance. Atenolol is also used cautiously, but may be less potent in this context. Multivitamins are generally not harmful. Strategy: on dialysis days, anticipate withholding antihypertensives unless otherwise directed. Always choose the option that interferes most with dialysis hemodynamics. Hey, I know this journey hasn't been easy. Maybe you felt overwhelmed, tired, or even doubted yourself. But I want you to know this: you are not alone. Every minute you've spent studying is a step toward your dream. You didn't come this far to give up. You've sacrificed sleep, time with family, and so much more. And it all means something. Picture the moment you see that pass on your NCLEX results. Imagine the pride in your eyes, the joy in your family's voice, the patients whose lives you'll touch. You're not just studying. You're preparing to become someone's hero. So hold your head high, wipe away the doubt, and keep going. You were born for this. Let's continue. 26. A nurse is educating a client with chronic kidney disease on potassium-rich foods. Which food should the client avoid? A. Apple. B. White bread. C. Baked potato. D. Cabbage. Answer: C. Baked potato. Rationale: potatoes are extremely high in potassium, especially when baked with the skin. Clients with CKD have a reduced ability to excrete potassium, and hyperkalemia can lead to fatal arrhythmias. Apples, white bread, and cabbage are low potassium foods and safer choices. Even soaking potatoes doesn't remove enough potassium to make them safe for regular intake in severe CKD. Strategy: learn and recall high potassium foods. Think B potassium. Bananas, potatoes, oranges, tomatoes, avocados, spinach, salt substitutes, and milk dairy. CKD questions almost always test your food knowledge. 27. A client with acute kidney injury is anuric. Which finding is most expected? A. Hypotension. B. Metabolic alkalosis. C. Hyperkalemia. D. Polyuria. Answer: C. Hyperkalemia. Rationale: anuria, no urine output, indicates severe kidney impairment. When kidneys are not producing urine, electrolytes like potassium accumulate, leading to hyperkalemia, which is life-threatening due to its cardiac effects. Hypotension is more common in volume-depleted states. Polyuria is seen in recovery phases or uncontrolled diabetes, and metabolic acidosis, not alkalosis, is the acid-base disturbance typically seen. Strategy: recognize electrolyte and acid-base complications of AKI. Anuria equals no excretion equals potassium, urea, and acids accumulate equals metabolic acidosis and hyperkalemia. A client is scheduled for an intravenous pilogram IVP. Which of the following findings requires the nurse to notify the provider immediately? A. Blood pressure of 140/88 millimeters of mercury. B. History of iodine allergy. C. Creatinine of 1.1 milligrams per deciliter. D. Mild nausea after drinking contrast. Answer B. History of iodine allergy. Rationale: an IVP uses iodine-based contrast dye, and a history of allergy to iodine or shellfish increases the risk of anaphylaxis. This is a contraindication unless the client is pre-medicated with steroids and antihistamines. The provider must be notified immediately to take precautionary steps or choose an alternative test. Creatinine is normal, BP is stable, and mild nausea is common and non-life-threatening. Strategy: in diagnostic testing questions, identify what contraindicates contrast dye. Iodine allergy and impaired kidney function, high creatinine, are the two major red flags. 29. Which laboratory result would the nurse expect to find in a client with end-stage renal disease? A. Low blood urea nitrogen, BUN. B. Elevated creatinine. C. Low serum potassium. D. Decreased phosphorus. Answer: B. Elevated creatinine. Rationale: in ESRD, the kidneys lose the ability to filter waste products, so creatinine and BUN levels rise significantly. Creatinine is a waste product of muscle metabolism and a key marker of kidney function. A low BUN or potassium would be unusual. In ESRD, potassium and phosphorus both tend to be elevated, not low, due to impaired excretion. Strategy: know lab values and their significance in kidney disease. When you see ESRD, expect increased BUN, creatinine, phosphorus, potassium, and decreased calcium and hemoglobin. 30. The nurse is caring for a client with newly diagnosed polycystic kidney disease. What is the priority teaching point? A. You will need to avoid all dairy products. B. Take your antibiotics until the cysts shrink. C. Monitor your blood pressure regularly. D. Limit your fluid intake to prevent kidney rupture. Answer: C. Monitor your blood pressure regularly. Rationale: polycystic kidney disease, PKD, is a genetic disorder causing fluid-filled cysts to grow in the kidneys, eventually impairing function. One of the earliest and most dangerous complications is hypertension, which accelerates kidney damage. Managing blood pressure can slow the progression of PKD and reduce cardiovascular risk. Dairy and antibiotics are not specific treatments. Fluid restriction is not recommended unless the client is in renal failure. Strategy: for chronic progressive diseases, focus teaching on slowing progression and preventing complications. In PKD, hypertension control is key. 31. A client on peritoneal dialysis reports that the drainage fluid is cloudy. What should the nurse suspect? A. Dehydration. B. Overhydration. C. Peritonitis. D. Electrolyte imbalance. Answer: C. Peritonitis. Rationale: in peritoneal dialysis, the clarity of the outflow fluid is a major indicator of the client's status. Normally, dialysate drainage should be clear or straw-colored. Cloudy or turbid outflow often indicates peritonitis, an infection of the peritoneal cavity, the most serious complication of peritoneal dialysis. This may be accompanied by abdominal pain, fever, nausea, or chills. Dehydration and electrolyte imbalance do not directly cause cloudy dialysate. Strategy: when a specific change in output is described, ask, is this a red flag for infection or obstruction? Cloudy peritoneal fluid always demands immediate attention. On NCLEX, infection equals cloudy fluid, especially in sterile procedures like peritoneal dialysis. 32. Which dietary instruction should be given to a client with uric acid renal stones? A. Increase intake of organ meats. B. Limit fluid intake to 1 liter per day. C. Avoid purine-rich foods like red meat and shellfish. D. Follow a high-calcium diet. Answer: C. Avoid purine-rich foods like red meat and shellfish. Rationale: uric acid stones result from elevated levels of uric acid, often due to purine-rich diets. Foods high in purines include red meats, organ meats, sardines, shellfish, and alcohol, particularly beer. These raise uric acid levels and increase stone formation. Hydration is actually increased, not limited, and high calcium diets are not specifically related to uric acid stones. Strategy. On NCLEX, identify stone types and pair them with their specific prevention strategy. For uric acid stones, avoid purines plus increase fluids plus alkalinize urine. Dietary teaching questions often test client-specific customization. 33. Which finding would indicate that erythropoietin therapy is effective in a client with chronic kidney disease? A. Decreased serum potassium. B. Increased urine output. C. Improved hemoglobin level. D. Decreased creatinine. Answer. C. Improved hemoglobin level. Rationale. Erythropoietin is a hormone normally produced by the kidneys. In CKD, the kidneys fail to make enough, leading to anemia of chronic disease. Synthetic erythropoietin stimulates the bone marrow to increase red blood cell production, leading to higher hemoglobin and hematocrit levels, which improves oxygen carrying capacity and energy. Potassium and creatinine are not affected by this therapy, and urine output changes are unrelated. Strategy. Always ask, what is the main purpose of the drug? If the drug affects the blood, look for blood-related lab values like hemoglobin, hematocrit to evaluate effectiveness. 34. A client receiving hemodialysis reports dizziness and nausea during the procedure. What is the nurse's immediate action? A. Stop the dialysis immediately. B. Check the client's blood pressure. C. Elevate the client's legs. D. Administer antiemetics. Answer. B. Check the client's blood pressure. Rationale. Dizziness and nausea during dialysis may be signs of hypotension, one of the most common complications of hemodialysis. This results from rapid fluid removal, leading to decreased circulating volume. The nurse must first assess vital signs, especially blood pressure, to determine the severity before taking further action. If hypotension is confirmed, interventions like slowing the ultrafiltration rate or placing the client in Trendelenburg position may follow. Administering medications before assessment is unsafe. Strategy. NCLEX prioritizes assessment before intervention. Unless it's an emergency requiring immediate action, for example CPR, you must assess first. Think. What's causing the symptom? Check vitals before treating. 35. What is the purpose of administering calcium acetate in a client with end-stage renal disease? A. To treat hypocalcemia. B. To bind phosphorus in the gut. C. To increase bone mineralization. D. To promote diuresis. Answer. B. To bind phosphorus in the gut. Rationale. Calcium acetate is a phosphate binder used in clients with ESRD to prevent hyperphosphatemia by binding dietary phosphate in the gastrointestinal tract, reducing its absorption. While it contains calcium, its primary purpose is not to correct hypocalcemia, but to control phosphorus levels, which also indirectly helps maintain calcium phosphate balance and reduce secondary hyperparathyroidism. Strategy. With ESRD drugs, know the purpose and mechanism. Calcium acetate equals phosphorus binder, not a calcium supplement. NCLEX may try to confuse you by emphasizing the calcium content. Focus on what it's prescribed for. 36. A client with acute kidney injury has elevated BUN and creatinine levels. What diet modification is most appropriate? A. High protein, high potassium diet. B. Low protein, high calorie diet. C. High phosphorus, low carbohydrate diet. D. High sodium, low protein diet. Answer. B. Low protein, high calorie diet. Rationale. In AKI, protein intake is often restricted to reduce the nitrogenous waste load measured by BUN. However, the client must still receive adequate calories from carbohydrates and fats to prevent catabolism of muscle for energy. As kidney function recovers, or in dialysis patients, protein needs may change. Potassium, phosphorus, and sodium are typically limited as well due to decreased excretion. Strategy. Nutrition questions require precision. Think about how the disease process affects metabolism. In renal failure, the priority is reducing waste production while maintaining energy needs. 37. A nurse is caring for a client with a Foley catheter. Which action best prevents catheter-associated urinary tract infection? CAUTI. A. Emptying the drainage bag every 8 hours. B. Irrigating the catheter with sterile water daily. C. Using sterile technique during insertion. D. Disconnecting the tubing during repositioning. Answer: C. Using sterile technique during insertion. Rationale: the most effective way to prevent CAUTIs is to ensure sterile technique during catheter insertion. Most catheter infections occur from introduction of pathogens at the time of insertion. Other preventative measures include maintaining a closed system, avoiding unnecessary disconnections, securing the catheter properly, and performing perineal care. Routine irrigation is not recommended and may introduce pathogens. Strategy: when asked to choose the best prevention method, go for the action that addresses the initial cause of the problem. In CAUTIs, insertion technique is the most critical control point. 38. A client is receiving Mannitol for treatment of increased intracranial pressure. Which renal-related lab value should the nurse monitor closely? A. Serum potassium. B. BUN. C. Serum calcium. D. Creatinine. Answer: A. Serum potassium. Rationale: Mannitol is an osmotic diuretic that increases urine output by drawing fluid into the renal tubules. This rapid diuresis can cause electrolyte imbalances, especially hypokalemia or hyperkalemia, depending on renal function. Potassium must be monitored closely to prevent arrhythmias. Creatinine and BUN are also relevant, but potassium changes can be rapidly life-threatening. Strategy: when a question involves a diuretic, your first thought should be, what electrolyte will it alter? For Mannitol, monitor fluid status, potassium above all. 39. Which client statement indicates correct understanding of self-care with a new dialysis access graft? A. I can check for the thrill each day. B. I'll use this arm for blood pressure monitoring. C. I should keep my arm elevated above my heart at all times. D. I should avoid protein in my diet to protect the graft. Answer: A. I can check for the thrill each day. Rationale: clients with AV grafts or fistulas should check for a thrill, vibration, or bruit, whooshing sound, daily to ensure patency. These findings confirm blood flow through the access site. Blood pressures, IVs, or blood draws should never be done on the access arm. Elevation is not continuously required, and dietary protein is not directly related to graft care. Strategy: when teaching about vascular access, emphasize protection and monitoring. Clients need to know how to assess the function and integrity of their lifeline.
40. Which symptom is most indicative of fluid overload in a client with kidney failure? A. Thirst. B. Hypotension. C. Crackles in the lungs. D. Dry mucous membranes. Answer: C. Crackles in the lungs. Rationale: fluid overload in kidney failure often leads to pulmonary edema, causing crackles, dyspnea, orthopnea, and even respiratory distress. This is due to fluid shifting from the vasculature into the alveolar spaces. Hypotension and thirst usually indicate fluid deficit, and dry mucous membranes are not typical with volume excess. Strategy: in fluid-related questions, identify where the fluid goes. If it's overload, think weight gain, edema, hypertension, crackles. If it's dehydration, think dryness, thirst, low BP, tachycardia. 41. A client with chronic kidney disease has a serum potassium level of 6.2 milliequipiates CELA. Which assessment finding is the most concerning? A. Muscle twitching. B. Nausea. C. Tall peaked T waves on ECG. D. Abdominal cramping. Answer: C. Tall peaked T waves on ECG. Rationale: a potassium level of 6.2 milliequipiates CELA indicates hyperkalemia, which can have dangerous effects on the heart. Tall peaked T waves are an early ECG sign of hyperkalemia and can progress to ventricular arrhythmias or cardiac arrest. While muscle twitching, nausea, and cramping are also symptoms of elevated potassium, cardiac manifestations are the most life-threatening and must be treated immediately. Strategy: when the NCLEX question asks for the most concerning or priority symptom, always look for signs that indicate imminent danger to vital organs, especially the heart or brain. In hyperkalemia, ECG changes equals emergency. 42. A nurse is monitoring a client with acute glomerulonephritis, which finding requires immediate attention. A. Brown-colored urine. B. Periorbital edema. C. Blood pressure of 190/110 mmHg. D. Positive protein in the urine. Answer. C. Blood pressure of 190/110 mmHg. Rationale. Severe hypertension is a critical complication of acute glomerulonephritis. A BP reading of 190/110 mmHg puts the client at risk for stroke, heart failure, and further kidney damage. While brown-colored urine, proteinuria, and periorbital edema are expected findings in glomerulonephritis, such extreme hypertension requires immediate medical intervention to reduce the risk of a hypertensive crisis. Strategy. When all options are abnormal, pick the one that represents the greatest immediate threat to life. On NCLEX, extremely elevated blood pressure with end organ involvement is always a high priority. 43. The nurse is preparing a client with end-stage renal disease for hemodialysis. Which pre-procedure task is most important? A. Have the client void. B. Assess for a bruit and thrill over the access site. C. Hold all oral medications. D. Administer a high-protein meal. Answer. B. Assess for a bruit and thrill over the access site. Rationale. Before dialysis, the nurse must assess the AV fistula or graft for a bruit, auscultated swishing sound, and thrill, palpable vibration, to confirm patency. If absent, dialysis cannot proceed. Voiding is not needed since the client is likely oliguric and uric. Not all medications are held, only those like antihypertensives that may cause hypotension. High-protein meals are not typically given pre-dialysis. Strategy. When asked about pre-procedure care, choose the action that ensures safety and functionality of the procedure. Here, ensuring vascular access is functioning properly is essential. 44. A client receiving peritoneal dialysis has a sudden decrease in outflow of dialysate. What is the nurse's priority action? A. Reposition the client. B. Notify the healthcare provider. C. Irrigate the catheter with saline. D. Lower the drainage bag below the abdomen. Answer. A. Reposition the client. Rationale. A sudden decrease in peritoneal outflow is usually due to mechanical obstruction, often from the catheter tip resting against internal organs. Repositioning the client, e.g., turning side to side or sitting upright, can dislodge the catheter tip and restore flow. Irrigation may not be allowed without orders. Lowering the bag helps with gravity, but won't fix mechanical obstruction. Notify the provider only if interventions fail. Strategy. For dialysis troubleshooting, think, can this be fixed non-invasively first? Repositioning is a safe and immediate nursing action. Always try that before escalating. 45. A nurse is teaching a client with chronic kidney disease about sodium intake. Which statement indicates effective teaching? A. I will avoid canned soups and salty snacks. B. I can season my food with salt substitutes. C. I only need to limit salt if my blood pressure is high. D. I should avoid sugar more than salt. Answer. A. I will avoid canned soups and salty snacks. Rationale. Clients with CKD must limit sodium intake to prevent fluid retention, hypertension, and heart strain. Canned soups, processed foods, and salty snacks are high in sodium and should be avoided. Salt substitutes are often high in potassium, which is also restricted in CKD. Sodium restriction is necessary regardless of BP, and sugar limitation is less urgent unless the client has diabetes. Strategy. In dietary teaching, the correct answer will reflect specific, measurable, and relevant behavior. Look for evidence that the client understands real-world application, like food labels and examples. 46. A nurse is assessing a client with a urinary tract obstruction. Which symptom is the most expected? A. Decreased creatinine. B. Decreased BUN. C. Increased urine output. D. Flank pain.
Answer. D. Flank pain. Rationale.
Urinary tract obstructions, e.g. from stones or tumors, lead to backflow of urine into the kidney, causing hydronephrosis and flank pain, which may be dull or severe. Urine output is typically reduced or absent. BUN and creatinine levels increase due to decreased clearance, not decrease. Flank pain is a classic early symptom of obstructive uropathy. Strategy. When a question involves kidney obstruction, think about anatomical effects. Where does urine go if it can't drain? Back into the kidney, causing pressure and pain, especially in the flank area.
47.
A client has just returned from hemodialysis. Which is the most important nursing assessment?
A. Appetite level. B. Level of fatigue. C. Access site for bleeding. D. Pain at the fistula site. Answer. C. Access site for bleeding.
Rationale. After hemodialysis, the fistula or graft used for access is vulnerable to bleeding due to anticoagulation during dialysis. The first nursing priority is to assess for active bleeding, hematoma, or loss of thrill or bruit. Fatigue is common but not urgent. Pain can occur but is not the priority. Appetite is not immediately relevant. Strategy. Think about the first potential complication after any invasive procedure. Here it's bleeding, so check the site immediately upon return from dialysis. 48. The nurse is caring for a client with kidney disease who develops small respirations. What is the most likely cause? A. Respiratory alkalosis. B. Metabolic acidosis. C. Hypoglycemia. D. Hyperkalemia. Answer. B. Metabolic acidosis. Rationale. Small respirations are deep, labored, rapid breaths that occur as a compensatory mechanism for metabolic acidosis, a common complication of kidney disease. In CKD, the kidneys fail to excrete acids and retain bicarbonate, leading to acidosis. The lungs try to blow off CO2 to correct pH. Respiratory alkalosis would have shallow breathing. Hypoglycemia and hyperkalemia do not cause small breathing. Strategy. Know the compensatory patterns. Metabolic acidosis, small respirations. Metabolic alkalosis, slow, shallow breathing. These patterns are high-yield NCLEX topics. 49. A client is admitted with nephrotic syndrome. Which laboratory finding should the nurse expect? A. Hypoalbuminemia. B. Hyperkalemia. C. Decreased urine protein. D. Elevated hemoglobin. Answer. A. Hypoalbuminemia. Rationale. In nephrotic syndrome, the glomeruli become highly permeable to proteins, especially albumin, resulting in massive proteinuria and hypoalbuminemia. This causes fluid to shift into tissues, leading to edema. Potassium levels are usually not the focus, and urine protein increases, not decreases. Hemoglobin may decrease due to hemodilution, not increase. Strategy. Know the classic triad of nephrotic syndrome. 1. Massive proteinuria. 2. Hypoalbuminemia. 3. Generalized edema. NCLEX often tests these hallmark findings together. 50. A client is prescribed sodium polystyrene sulfonate, CAUTI. Which finding indicates the medication is effective? A. Increased bowel sounds. B. Serum potassium of 4.5 MEq/liter. C. Decreased serum calcium. D. Relief from constipation. Answer. B. Serum potassium of 4.5 MEq/liter. Rationale. Sodium polystyrene sulfonate, CAUTI, is given to treat hyperkalemia. It works by exchanging sodium for potassium in the intestines, causing potassium to be eliminated in the stool. A potassium level within the normal range, 3.5 to 5.0 MEq/liter, confirms the drug's effectiveness. Constipation is a side effect, not a goal. It does not affect calcium. Strategy. For medication questions, match the mechanism of action with the desired outcome. CAUTI equals lowers potassium, so effectiveness equals normal potassium lab.
If you found this helpful, don't forget to like, share, and subscribe. And remember, mastering these high-yield questions brings you one step closer to wearing that RN badge with pride. You've got this.